Yeah. And your PCP won't sign it?
I think so.
Yeah.
Ready? But they should.
Go from whatever
Yeah.
that's what I do.
I just typed it into my phone, that's why I was waiting for one to just like.
Okay, so it's all, so that way, he goes back to the foundation.
And then pull up locations.
Yeah, we went and got one. It's like, can you take these off?
Alright, you guys, you about ready to start back up?
And now we're. I'm never gonna wear it.
That's all that you're
I don't want you to know what I do.
You're not finding that going there. So like, clinicals and whatnot in the hospital.
I run the patients.
I mean, I have a workaround.
You should have shown her our little PSA thing. This is when it's okay. Wake up hours. I was gonna say, take a nap.
I watched the video at first. I was like, oh.
So let's take bathrooms.
He did. I did.
Face is all slow.
Wait for my car.
That's cool.
Oh, I love doing it. I can tell them shit. I was gonna set that as well. I do not have to go. No. It was 55. That's right by my house. No. I set up what kind of bloods do you take? I take this. Oh, that's alright. Any questions before we start back up? No? Like, alright. Okay. So just a few more things then to talk about the skin, and then we'll move on to our second PowerPoint of the day. But these next couple slides are just a reminder of how the skin helps us regulate temperature. We already talked about sweat as a way to cool down. But another way that your skin helps with your body temp is based on the blood flow it has going through it. So that's kind of what they're trying to show you here. Whenever you, if you look at this picture here first, have vessels in your skin constrict, well, that means less blood is flowing to the skin. And that's what happens when you're trying to conserve heat, right? So if you're walking around in Minnesota in January, right, it's 20 below outside. Obviously your body temp, if you're outside, is gonna start to drop. And one of the ways your body conserves heat is to get those skin vessels to constrict so that the blood doesn't flow to the surface as much. And so you retain more heat in terms of your blood in the core of your body. And that's why, of course, if you're out walking around when it's that cold, again, your skin tone may look a little pale. Then, of course, if you are in a environment where it's 115 degrees outside, the vessels in your skin tend to dilate. So you've got more blood flowing to the skin, and with more blood flowing to the skin, you can lose more heat across the epidermis, as they're trying to show you. And of course, when you're outside and it's that hot, you may look a little flush, right? And that's, again, all of those vessels in the skin that are dilating, more blood flow, more heat loss. So it's a great example of what we call negative feedback, kind of the same way a thermostat works in your house, right? If your house is hot, then you turn on the AC, and the AC brings the temperature back down. It's kind of the same way body temp works with our skin. Okay. And then the last part of the presentation is just a little bit more about skin conditions. You know, again, when you guys get to block 2 in the summer, that's when we teach a lot of the pathology of the different systems. So I've been doing that with the other class the past few weeks. And one of the topics I discuss with them are skin disorders. And so this will be a little bit of a preview to when I come back in block 2 and do that with you guys. But, what's that? Yeah, so the first disorder that we'll take a look at here are burns. You know, again, the skin can be damaged by a lot of things, burns being one of those things. So whether that be fire, or whether that be some sort of hot surface, or as we were talking about earlier, too much UV light, or electrical current, or chemicals, those are all things that can burn the skin. And obviously you see a pretty grotesque example of that over there. You know, when it comes to determining how much of the skin has burned, there is a very simple way to estimate that called the rule of nines that I'm sure you've probably heard of before whenever you hear a news story of somebody that had burns on, you know, 60% of their body, or, you know, 80%. And the way that they do this to garner an estimate is the body is divided into 11 areas of 9%. Yeah, so that's why they call it the rule of nines. So if we count up here with our picture, if you take the head region, the front of the head is 4.5, the back of the head is 4.5. So there's one of our nines. Okay. Then if you look at the front of the chest and the abdomen, that's 18%. So that's 2 more nines. And then if you look at the back and the buttocks area, that's 18%. So that's 2 more nines. So we're up to 5. If you look at each upper extremity, the front is 4.5, the back is 4.5. So that's 2 more nines. So we're up to 7. If you look at the lower extremities, the front is 9 and the back is 9. So of course that would be 1, 2, 3, 4. 1, 2, 3, 4, there's 11. So that's 99%. The remaining 1% is the genital area, yes. And there's your 100%. Yes, usually every year, I don't know if that's what you're laughing at, but there's usually somebody that will say, oh, my genital area is 10% or so usually we hear that from the males as opposed to the females.
What's 1%?
So, if yours is bigger than 1%, then something else has to be sacrificed. One of the other areas, I suppose, to add up to 100%. So.
And my buttocks is like 16.
Your buttocks is 16, yeah.
Yeah.
So there you go. So, with the rule of nines, you can estimate then the total area of skin that has been affected, right? And obviously, as that number goes up and up and up, it becomes more and more concerning, right? The severity of a burn is usually determined by the first, second, third degree connotation that, again, I'm sure many of you have heard of before. If somebody suffers a first degree burn, and probably all of us have done that at one time or another, what that means is that the skin will definitely get red. It usually doesn't blister, and it's pretty minimal damage, and usually it is confined to the epidermis, okay? And, you know, you'll have some minor discomfort, so yeah, a typical sunburn, or maybe you inadvertently touched the hot stove, or, you know, the water in the shower was too hot, or something like that. Second degree, the skin definitely blisters, much more painful, it does swell, and the damage has extended into the dermis now with a second degree. And usually with second degree burns, you will have the remnants of some scar tissue that will build up, that will be noticeable on the skin probably for the rest of your life. If you have a third degree burn, then you're into the subcutaneous layer. Okay, so you've penetrated the epidermis, the dermis, now you're in the subcutaneous layer. And that means that you could also affect bone and muscle, kind of like what we saw in that electrical burn a few slides ago. And the real concern, of course, with third-degree burns is infection, right? Where it's easy for bacteria and other types of pathogens to get into the body. Folks that have third-degree burns may also not have a lot of pain because they've destroyed all the nerve endings in that part of the skin as well. And there can be a tremendous amount of fluid that's lost from the body as well. So obviously with third-degree burns, the risk of fatality is much, much higher. So we'll talk more about burns in block 2. This is, again, just a little bit of a preview into it. So
There's a fourth too, yeah. Charring is fourth.
what's that?
The fourth degree is charring.
What do you mean by charring? Oh, you're talking about, yeah, yeah, I've seen some, people take it a step further with 4th degree. I mean, usually with 4th degree, yeah, you can see charring and things like that. Some people call a 3rd degree a full thickness. Some people call that 4th degree as well. So you can have some slight differences in the definitions. But, so. And then again, 1st, 2nd, 3rd. Maybe some of the charring. Okay. All right, and then another thing that we'll talk a little bit about here as well, just because this is Arizona, and you will see this from time to time, skin cancer. So if we recap some of the things we talked about earlier, so there's the epidermis, this dark purple stuff that they stained with the histologic image. Remember, it's made up of stratified squamous epithelium. Remember, the bottom of the epidermis is made up of those basal cells, right? The stem cells. The cells in the middle are mostly keratinocytes that are stratified squamous cells. So that's, again, recapping what we talked about earlier. Now, the reason why we're doing this is because skin cancers are named after where they originate from within the skin. So let's take a look at this guy first. This is what we call BCC, basal cell carcinoma. It is the most common form of skin cancer here in the United States. And basal cell carcinoma is when that bottom row of cells in your epidermis start uncontrollably divide and divide and divide and divide. And as they divide and grow and divide and grow and divide and grow, they become cancerous and they'll produce a mass on the skin. And that mass is what we call basal cell carcinoma. And usually these are lesions that you can see here on the nose, over here, do not look normal. And just by looking at it, you can't tell what it is. Probably a really good dermatologist can. But of course they always biopsy this, right? They have to look underneath the microscope to be able to determine what type of skin cancer it is. But this type of skin cancer usually grows in sun-exposed areas. So this is one of those types of cancers that we associate with sunlight exposure. And the good news about basal cell carcinoma is that these grow very, very slowly and hence do not have as high of a risk of metastasizing, which means what? It spreads to other places in the body. That's correct. They rarely do that. Okay. They could, but chances are very, very low. So what that means is that if they remain confined on the surface of the skin, you can remove them. But in doing so, of course, you can leave behind some disfigurement and scarring, which down the road, you can obviously, have somewhat corrected with plastic surgery and things like that. So you can see that close to 1 million people per year here in the U.S. are diagnosed with basal cell carcinoma. And as long as you catch it early, you can make a full recovery, and the prognosis is usually pretty good. These are not contagious, so if you were ever to touch one of these or anything, it doesn't spread from one person to the next. There are skin infections that can do that. We'll talk about those in block 2 that you want to steer clear of, like impetigo and stuff like that. But these are not contagious. The second most common type of skin cancer is what they call squamous cell carcinoma, SCC. And What happens here is that the cells in the middle layers start to grow and divide, grow and divide, grow and divide out of control. Okay, so in basal cell, it's the bottom layer. In squamous cell carcinoma, it's the middle layer. And with squamous cell carcinoma, this also usually occurs with sunlight exposure. The big difference with squamous cell, the lesions look the same, so it's hard to distinguish between them without a biopsy. But these tend to be a little bit more aggressive. Okay, so they tend to grow a little faster, and because of that, they could metastasize. There's a higher risk of that happening. So these you definitely want to catch earlier. And if you do, once again, the prognosis is usually pretty good. But if there's any evidence of metastasis, then usually you're looking at radiation, chemo, that kind of thing, in addition to removing the lesion from the skin. The worst type of cancer is what they call malignant melanoma. Now, this is a type of cancer that is small in number. It makes up about 4% of all cancers, but it's the most deadliest. Okay. And which cells become cancerous here? The melanocytes. Yeah, they're the ones that are growing and dividing and growing and dividing and growing and dividing out of control. That's exactly right. And of course, they make melanin. So when you have melanomas, they usually stand out. Okay, they look dark. Because as those melanocytes grow and divide, they make lots and lots and lots of melanin. But with that said, they can be easily confused with things like what? Moles, freckles, yeah, stuff like that. Now, once again, a trained dermatologist can spot these pretty well. They're still going to biopsy them. But some of the differences between a mole versus a malignant melanoma, number one, moles usually have a pretty smooth border around them. Okay? Melanomas tend to have a more jaggedy border around them. Okay, it's not as well circumscribed. So you can see that here. Moles usually have uniform color. Melanomas do not. So when you look at some of these pictures, you can see that there are different shades of color, right? Darker, lighter, medium, right? Usually moles, the color is uniform. Not always, but oftentimes it is. Sometimes melanomas may form cysts like these did down here that are quite noticeable. Okay? Now again, not all melanomas do that, but some do. But once again, you have to biopsy to make sure to definitively diagnose somebody with malignant melanoma. Unfortunately, by the time many people get diagnosed with these, there is metastasis already to other places in the body, and that's what makes them very deadly and challenging to treat if it spreads to liver or the brain or whatever else. So these absolutely have to be caught early to have a good prognosis. And of course, these are also associated with more and more skin sunlight exposure. Okay, and then a few other disorders. Psoriasis, we'll talk more about this in block 2 as well. Psoriasis is basically an autoimmune type of disorder where your immune system begins to affect your skin. And in psoriasis, you'll start to get these lesions that are very scaly, and they start to become kind of dry and irritated. And when they occur on places of your skin that are normally exposed, like the face, they can make people very self-conscious. If they're hidden, not as much. This is also not contagious. You don't have to worry about contracting psoriasis from a patient. And when people get psoriasis, it can be just a little tiny area of skin. It can be several areas, so it varies quite a bit. The good news about psoriasis is there are better and better treatments out there. What they call monoclonal antibodies. You may have seen advertisements for drugs like Skyrizi and some of these other newer ones that are more optimal therapies than some of the more conventional methods. So still not a cure, but it can at least control the size of the lesion and how it looks and things like that. And then of course you guys will see plenty of ulcers. We'll talk more about these as well in block 2. whenever you see what they call decubitus ulcers, you've pretty much got a complete breakdown of the epidermis. Okay? And the dermis is exposed, and you may even have exposure underneath the dermis too. So these generally will look red, they can bleed. And when you have somebody that has decubitus ulcers, what's happening is that their area of skin that is affected is being constantly compressed up against a bone. And when that happens, you begin to block blood flow, right? You start to kink off the blood vessels. And now you have an area of the skin that is not getting blood flow, and it starts to break down. Okay? And this example here, of course, is a heel, and of course, what can happen here? Well, if you have somebody who's constantly lying in bed, right, and their heels are pressed up against the bed constantly, they're not getting up, yeah, you can get an ulcer that can form on the back of the heel. Okay. Where else can you see them?
On the butt.
Right above the butt crack, yeah, right? So again, somebody lying in bed, and the pelvis and the sacrum is compressed against the bed, and again, you block blood flow. And certainly there are some patients that are more at risk for this, like diabetics, for instance, who normally have poor circulation. And of course, when this begins to happen, you get concerned that this ulcer can grow and grow and grow. It can get infected, you can't treat it, and then what? Then you have an amputation that you have to deal with. Well, gangrene will usually settle in, and then you have to amputate so the gangrene doesn't spread throughout the limb.
Her ulcer was like this big on her bottom, and you could see her coccyx.
Yeah.
So she'd be scratching at it too.
Yeah, the ones that occur right above the butt crack can get really problematic. So, and you're right, sometimes you'll have so much breakdown of tissue that you can see part of the sacrum or the coccyx.
If it gets that bad, can it like heal still, or is it once it's that bad, it's that bad?
The goal is to try and heal. I mean, they debride them as much as they can. They may use Whirlpool to try and kill bacteria and things like that. Dress it up.
Is that where the whole like wound vac thing?
Yep. Yep. They'll use wound vacs, so they'll try everything they can. You know, the tough thing about the ones above the butt crack is that you can't amputate anything there. I mean, if it's yeah, you can't do that. So. All right, and then infections. I didn't include a lot here because, like I said, we talk a lot about skin infections in block 2. But just to give you a little bit of a flavor of this, this is tinea, which is a fungal infection of the skin, and this is a very common type of infection that a lot of people can get. There are different forms of tinea. It's all the same fungus, it's just a matter of where it grows on the skin. If the fungus grows on the trunk of your body, like on your chest or your abdomen, we call that tinea corporis. If it grows in the scalp, we call that tinea capitis. If it's in the groin area, that is crurus. And then if it happens in the feet, so-called athlete's feet, right, that's called tinea pedis. And fungal infections can be easily picked up from, obviously, places like showers. Tinea loves moisture. And then if it infects your skin, it can cause a lot of burning, cracking, fissuring of the skin. And then you have to treat with antifungal medications. Either you apply directly with a spray or a cream, or you can take oral antifungal as well. Tinea is definitely contagious, so you always want to protect yourself from tinea if you ever see it on somebody's body or feet or something like that. You can get it from contact to contact with skin, yes.
That's ringworm.
Ringworm is another name, another generic name they use when it's on the body, like on your trunk. Yeah. There are lots of bacterial skin infections. I didn't include any of them here. I mentioned impetigo before. And there's others as well. We also, in block 2, talk about parasitic skin infections. So those are things like lice and scabies that you want to protect yourself from too.
What about staph?
So, because staph you can get from contact to contact with skin.
I can smell it when you say it.
What
about staph?
Staph is bacterial. Yep, that's bacterial.
Staph's nasty.
Yeah. So yeah, I just did that lecture for the Block 2 students a couple weeks ago, so where we did all the skin types of infections. So you guys will see me in the summer for that. Like I said, we'll talk a lot about what you have to protect yourself from and things like that whenever you see it. So. Cool. Any other questions before we exit out of this part? Okay, all right, let me close up this one. And the next one we're gonna do is skeletal part 1. Let me open that one up. There we go. Okay. So part 1 of our skeletal system that we're gonna do today, we're gonna mainly focus on how bone develops, how it forms, how you maintain your bone mass. We'll talk about bone cells, things like that. Part 2, which we'll do next week, we'll take a tour through the skeleton and name all the bones and identify them. Anybody know how many bones there are?
206.
206, yeah, 206. 206 is the magic number.
Well, I have like 210.
You have 210 right now, yeah, because you have fractured bones, yes. You have metatarsals, as you told me. So yes, 206 bones altogether. And you might be thinking, wow, that's a lot of names to learn, but remember you have a lot of duplicates. So, because, you know, your lower extremity bones, you have mirror images of, and the same with your uppers. And so it's not as daunting as it may initially seem when you're thinking, oh my God, 206 bones. Not that bad. But anyway, that'll be next week. Today we'll focus just on part 1 here, which I said is covering other things. So, all right, so let's do it. Just like we did with skin, right? We started off by talking about functions of skin. Well, what are functions of bones? Well, certainly one of the first things that comes to mind is support. And that's particularly true of many of the bones that we have within the axis of our body, as we like to say, where you have your vertebrae and you have your pelvis. Certainly those bones help support the lower extremities. Second thing is protection. I mean, not all bones protect things, but you know, when we were discussing the nervous system a few weeks ago, we know that the skull bones protect the brain. The bones of the vertebrae protect the spinal cord. Some bones, of course, produce a lot of movement. That's especially true when we're talking about the extremities, right? So when we talk about the femur and the tibia and the fibula and all the movements that occur in the lower extremities, and then the same thing up here with the upper extremities when it comes to the humerus and the radius and the ulna. Bones store a lot of minerals. And of course, the main one is calcium. So calcium is what gives bone its hardness and its strength. But bones also store a lot of calcium because other tissues in the body need it. And the bones are a great reservoir, kind of like a warehouse, to store calcium if ever tissues need it. So we'll talk more about that later on today. Of course, deep within our bones, many of our bones, certainly not all of them, you have your bone marrow. And of course, what does bone marrow make?
Red blood cells.
Red blood cells, white blood cells, platelets. Yeah, what we call hematopoiesis. Which bones have a lot of marrow in particular?
Long bones.
Yeah, the femur, yeah. Yep, the femur has a lot of marrow, particularly up here near the pelvic bones and the hip joint. What else? Anybody else? Ribs have a lot of marrow. The tibia, not as much as others, but it has some. Your vertebrae have a lot of bone marrow. Yep. Your clavicles do, right? But when you get out to the distal parts, like your fingers and your wrists and your ankle bones, you tend not to have as much marrow. So your wrist is kind of like the tibia.
I was just
Little
thinking like
amount.
the IO side.
Yeah. Sternum has a lot.
The sternum.
Sternum has a lot of marrow, along with the ribs. Yep. Yeah. And unfortunately, as we age, the amount of bone marrow declines. So our ability to make red cells and white cells and platelets will definitely decrease as we get older. And then energy storage, what that's in reference to is that in many of your long bones, like the femur, the tibia, you actually have fat inside. So if somebody ever told you you have fat bones, technically they're right. So you do have fat that can be used for energy. So.
Bones that have more marrow in them, are those the ones we're more concerned about when they break because of bleeding? Does the marrow have?
Yeah, it's
deal with
not
that?
like marrow bleeds, but as I'll show you guys later on, you do have a lot of blood vessels inside of bones. So when you fracture a bone, you actually fracture blood vessels too. And that happens immediately when you fracture a bone. You form what we call a hematoma, which is a mass of clotted blood at the fracture site. So there'll be some better pictures that I'll show you later on where you'll be able to kind of visualize that. But I mean, literally within every single bone, you've got blood vessels. All of your bones have holes on the surface that blood vessels penetrate. Because deep within bone, you have living tissue. There are cells that live there. And guess what those cells need? They need oxygen, they need nutrients. So you've got to have blood vessels that literally penetrate into the bone. When you fracture a bone, you're likely shredding some of those vessels. So.
We had a guy that had a femur fracture, got surgery, and then he had a fat, like, embolism.
Yeah.
Like an adipose tissue that got stuck somewhere in
Yeah.
his abdomen.
Yeah.
And he was like distended to all crap. They took out 3,000 of them.
Yeah, the fat, as I'll show you, lives in the shaft of the long bones. So when someone fractures something like a femur in the shaft, that's where the fat is. And you're exactly right. Unfortunately, what can happen sometimes is you have a piece of fat tissue that breaks away, it works its way into a blood vessel, and it becomes nervous.
Right.
When you fracture the femur up at the hip, you're less likely to see that. There's not as much fat stored up here. Very little, if any. Usually in the shaft is where you see it.
Well, yeah, but I'm
Shaft.
meaning like when we did
So when people say when bones heal, they feel stronger, right?
We're gonna talk about fractures and healing coming up, yeah? Yeah, can it heal stronger in some ways? Yeah, I'll show you that. You know, in many people, when you have a fracture, when the bone repairs itself, it usually kind of goes a little bit of an extra mile to make sure that it's really reinforced so that it doesn't fracture again. The only problem with that sometimes is that if you repair and you build up a lot of extra tissue here within the fracture area, depending on where it is, it could restrict mobility to a degree, things like that, form spurs. So, yeah, we'll talk more about that coming up too. All right, good. Anything else? Okay, bone types. This is not terribly exciting, but you know, you can describe bones having different shapes. And based on the shape of the bone, you can kind of categorize bones into these different types that they're showing you here. So of course, you've got long bones, which is pretty self-explanatory, right? So here we have the humerus, which is the only bone in your arm. So you're gonna get some terminology here, right? Technically, this whole thing is not an arm, right? Your typical patient refers to this whole thing as their arm. Technically, this is what we call the upper extremity. The arm is where? Shoulder to elbow. Yeah, technically that's your arm. Elbow to wrist is what we call the forearm. Good, yeah, exactly, okay. Same thing here, that this whole thing is not a leg. It's your lower extremity, okay? From hip to knee, that's what we call your thigh. From knee to ankle, that is your, not the fourth thigh. That's what we call the leg. Okay? So when you hear somebody say that the humerus is the only bone in the arm, again, that's shoulder to elbow. Okay? The bones of your forearm would be your radius and the ulna, yeah, right. And then in your lower extremity, the femur is the only bone in your thigh. The leg bones technically are your tibia and your fibula. Yeah, yeah, not tibia and fibia. Tibia and fibula. Yeah. So, All right, then you have short bones. Short bones are basically bones that roughly are equal in length, width, and height. Now, if that were true, you would have a cube, right? So it's not perfect, but short bones kind of are cube-shaped for all intents and purposes. So many of the bones that we call carpal bones, which are in your what? Wrist, yeah, wrist, are examples of short bones. Then you've got bones that are flat, like the sternum. The ribs are essentially flat. They're curved, but they're flat. And then you have irregular bones, which are neither long, short, or flat. So they dump them into that category, kind of like a miscellaneous category. So vertebrae are a good example. If they're not short, they're not flat, and they're definitely not long, so we just call them irregular. Sesamoid bones are round. So a good example is the kneecap, the patella. So we don't have very many examples of sesamoid bones, but the kneecap would be a good example of that. All right.
That's a sesamoid bone as well?
Some people may have a sesamoid bone underneath a metacarpal. Yeah, like right here with the thumb. Not everyone has that. Some people do, some people don't. So when I said 206, that's typical. But could somebody have an extra bone here and there? Sure. And oftentimes they may have some sesamoid bones in places like an ankle or thumb or something like that. But not everyone necessarily has those. But everyone should have kneecaps normally.
So is this kind of the same thing like with Wolff Parkinson's disease in the heart? There's the other like highway, I forgot what it's called, something, but Kevin, I don't know.
Kent.
Oh, there you go. Yeah. So is it like based? This might sound dumb, but like has some people like evolved a little more where they have more bones, less bones? Why do some people have some things and other people don't?
Yeah, I mean, a lot of the genetic variation that you see in people when it comes to different tissues, a lot of people believe that they are just genetic anomalies where genes change over time. Is it necessarily an evolutionary thing where having an extra bone, let's say, gives you some sort of advantage? Maybe. Again, no one knows for sure. But oftentimes when you see stuff like this, it's a type of genetic mutation that occurred, but not a mutation in the sense that it's causing you disease or causing you harm per se. It's a mutation that, again, it's just there, and it's not giving you any disease or any extra advantage, but it probably is the result of many mutations that have just been passed down over the course of time. So
Like genetic possibly?
oh yeah, definitely genetic.
As with people, like extra appendages.
Extra appendages, yep. I mean, certainly that happens. You know, with, let's put it this way, when you have somebody that is born and you have a lineage of people, you know, again, genes have to be duplicated, right? And you've got 35,000 genes in your genome that have to be duplicated, and there's bound to be a mistake here and there. Unfortunately, some of those mistakes do lead to disease. Okay. But sometimes mistakes are made, and it doesn't lead to disease, but you're going to express some sort of variation because of that mistake that was made in copying your DNA. All right. So, what bone is this over here? Anybody know?
Femur?
That's a tibia. Yeah, that's a tibia right here. Over here is a fibula. So those are examples of long bones. This is obviously a drawing. This is a real one over here. A snapshot. And when you're talking about long bones, once again, there's some more terminology that you'll come across. The very ends of a long bone, each end is called an epiphysis. Yeah, an epiphysis. So when it says SIS, that's singular. If it SES, epiphyses, that's plural. Okay. So this is the top of the tibia that would be close to your kneecap. So this we would call the proximal epiphysis. And then the one down here by the ankle we would call the distal epiphysis of the tibia. Yeah. Okay. And long bones sometimes can fracture at the ends, right? Depending upon the type of injury. The shaft in the middle is what we call the diaphysis. Okay? So that's the diaphysis. Yep, and of course fractures can happen there, as we said earlier too. Now, when you look at the diaphysis of a long bone, a lot of people think that it is solid through and through, kind of like a brick. That's not true. When you look in the diaphysis, there is a cavity in the diaphysis. It's what we call the medullary cavity. And as I was telling you earlier, you find what we call yellow marrow in there, which for all intents and purposes is fat. Yeah, it's fat. Yeah. So all of your long bones, your tibia, your fibula, your femur, that's filled with yellow marrow. That's fat. Okay. And that can be used as energy by the cells that live in your bone. At the ends where you have the epiphysis, usually the top and the bottom of the epiphysis is lined with cartilage. We call that articular cartilage. We'll talk more about that here in just a bit. In this case, up here at the knee joint, it kind of forms a pad. That particular cartilage is given a special name called the meniscus cartilage. Good, yeah. And then periosteum, endosteum are membranes. So the inside of your medullary cavity is lined with a membrane called the endosteum. The surface of all of your long bones, all of your bones really, is lined with a membrane called periosteum. And the periosteum is what ligaments and tendons usually attach to on the surface of bones. You'll see some better pictures of that later on. And then you can see a fibula over here. They shaped it in half so you can see inside. So there's a medullary cavity. Now in this dead bone, there's no fat in there, right? It obviously deteriorated, but you can see that this medullary cavity is hollow, but in a living bone it would be filled with that yellow bone marrow. Now, as we look at this picture here, and as we go to this picture here, you may have noticed that when you look at the bone, it doesn't all look the same. Bone is made up of two types of bone tissue, or what we call osseous tissue. One of those types is what we call compact or dense bone. So if we go back to this picture, you can see that in the diaphysis, right, all along the periphery, that bone is pretty solid. That's compact bone. Okay, that does kind of look like a brick, right? And you can see that going all the way down the diaphysis, and it starts to thin out as you get down here to the epiphysis. Now, if you look inside the epiphysis, you'll see a different type of bone tissue. That is what we call spongy bone or cancellous bone. Okay, and you can see it right here. Okay. Now the reason why they call it spongy is because it kind of looks like a sponge, right? That you would have on your kitchen countertop to, you know, scrub the pots and pans with and do your dishes. If you ever are dealing with a real bone, don't ever take your finger and rub up against it, because all of this spongy bone is not soft like a sponge. It actually is composed of small little needle-like pieces of bone called trabeculae. And if you rub your finger up against it, you'll get little bone splinters that you'll have to try and get out with a tweezer or something like that. This stuff can be very, very sharp. There's a lot of open space, as you can see here. And normally that open space is filled with red bone marrow, okay, that makes the red cells and the white cells and all of that. Now, what's the advantage of spongy bone? Well, here's a picture of a femur, the head of the femur. Here's the head of the humerus fitting into your scapula at your shoulder joint. And the beauty of these trabeculae is this. They're strong, but they are lightweight. Okay, they are lightweight. They also can change over time. They can arrange themselves like little struts along lines of stress, because you put a lot of stress on epiphyses when you do a lot of movement. So the beauty of spongy bone is that it is flexible, it can change, but it's lightweight. Okay? Nobody knows for sure, but if all of your bones were made of compact bone, and your bones were literally like bricks, you know how much extra weight you'd pack on your frame? Again, no one knows for sure, but
Are bird bones more hollow or more spongy?
What's that?
Are bones like really hollow or really spongy?
Are bird bones more hollow or spongy? I don't know the answer to
They're
that.
hollow.
They're hollow.
Probably more
That's why they
hollow,
can
I
fly.
would envision, yeah, for enable them to fly. But if all of your human bones were made of compact bone, and they were solid through and through, how much extra weight would you tack on? Yeah, most people estimate about 120 pounds. 120 pounds. Now that's 120 pounds in bone mass. Now if your bones are that heavy,
Then your muscles have to be heavy.
then your muscles have to be heavier too, because your muscles have to move those bones. And most people estimate that you'd probably need another 120 pounds of muscle mass. So now you're up to 240. Yeah, exactly, right. Yeah. So the really cool thing about spongy bone is that it is still strong, but again, it's lightweight. It's lighter weight.
So it's a limited interval.
So, there you go. All right. Now, what is bone actually made of? Okay. Well, let's talk about the composition of bone. Okay. So, no matter if you're talking about compact or spongy bone, first thing you have to realize is that again, bone is a living tissue. Okay. It's not dead stuff. So, bone has cells, and those cells are alive, and they need oxygen, they need nutrients, they need minerals, they need electrolytes. Okay. So, bone contains cells. The cells are surrounded by what we call the extracellular matrix. Okay? And the ECM, as we like to call it, consists of a lot of collagen fibers, right? Remember, collagen is a protein. So a very similar type of collagen that you have in your skin is also found in your bone. And then you have what we call the ground substance, otherwise known as the osteoid, kind of the cement, as I like to think of it, of the bone. And this is a mixture of water, a lot of organic material, what we call glycoprotein, proteoglycan, and then you have salts, the minerals of the bone, which I told you earlier is mainly that guy there, calcium, but also a little bit of phosphate thrown in there as well. Okay. So when you mix all this stuff together, you basically have bone. And probably one of the most important things to realize about this mixture of all this stuff is you need the right balance. Okay? It's like a good cookie recipe, right? So if there's anybody out there that bakes or cooks, you know that one of the things you have to get right is just the perfect mix of the ingredients, right? You don't want too much sugar or too little salt or too little chocolate chips or whatever is in your cookie recipe. And it's kind of the same thing here. If you want bone to look normal, if you want bone to behave normally, you need a proper balance of all of these things that you can see here. And there are some very easy experiments that you can do to convince yourself of that, which is what this picture is all about. So, we don't recommend doing this with human bones, even if you have access to them. But next time you have some ribs, or you have some chicken wings or something like that, save the bones. And if you want to do this with your kids or somebody, it can be a little science experiment. But take some of those bones, if you have yourself some ribs or whatever, and if you've got a bottle of vinegar that you can waste, pour the vinegar into a bowl, put your bones in the bowl of vinegar, let them sit there overnight. Wake up the next morning, your bones are going to be like rubber. You can literally twist them in a knot.
I think I did that for like my A&P class back in college.
Yeah.
And I forgot about it.
Of course.
By the time like I realized it was still there, it was like 2 years and I was moving out of my house.
The bones were sitting in vinegar for 2 years.
It wasn't there when I checked on it again.
The bones were completely dissolved.
Forgive them for 2 years.
It didn't smell.
It was on my desk in like a little
It was a
Rubbermaid
sealed
thingy.
container.
Yeah.
Oh, okay.
And I wrote my little essay on it and I just left it there. Wow.
That says a lot about.
There you go. Well, don't let it sit for 2 years. Let it sit for 24 hours, or just overnight, 12 hours, something like that. Take the bones out, that literally you can tie them in a knot. They are like rubber. So what happened? Well, that vinegar basically washed out all the minerals from the bone. So all the calcium, all the phosphate came out of the bone. So what does that tell you about the minerals? What kind of properties do they give the bone? Yeah, the hardness, the strength. Yeah, absolutely. Okay, because when you washed all those minerals out, the bone is no longer hard, right? It's very soft. Okay.
Technically, a bone is cartilage, just with.
Well, cartilage is soft. Well, it depends on the type of cartilage. We'll see. Not all cartilage is soft. Some cartilage is very tough. Yeah. Yeah. Now, the other experiment you can do with some of the other bones that you saved, don't put them in vinegar, but instead crank up your oven as high as you can get it. Right? Most ovens can get to about what, 550 or so. So, you know, get a cookie sheet, put the bones on the cookie sheet, put the bones in the oven for about a half an hour, let them bake at 550. Take them out, obviously get an oven mitt, all right? Take one of those bones, go out to your patio or your driveway, hold it up in the air and just let it go to the bottom, let it fall. Your bone's gonna shatter like that, okay? So what happened here is the high temps destroyed all of the collagen and all of the other organic material in the bone. It's all gone. So now, your bone is not very what? Well, it's strong, it's still hard,
It's not flexible.
but it's not flexible. It's not flexible. So it's more brittle. Okay? So the analogy I like to use here is like your windshield. Okay? Is your windshield pretty hard and strong? Yeah. Is it very flexible? Nope. Because all it takes is for one of those damn little rocks, right, to come up on the 60 as you're driving down the freeway and you get a chip. Because your hard, strong windshield can't absorb that little rock because it's not very flexible. Okay? That's kind of what's happening here. Okay? Your bones are hard, but they're not flexible, they're brittle. And that's not good either, especially for fall. Okay? So you need a balance of the collagen, the organic material, mineral, proper balance in order for the bone to look normal, behave normal, function normal. So.
Alright, so would you be able to repeat what the extracellular matrix is? You said it's something space, or it's all this space.
Yeah, so the best way to answer that, it's kind of coming up.
Okay, we can wait.
No, we'll jump ahead. So, look at that picture there. What is that stuff called? Rebar. Yeah, right? So if any of you have ever, seen the freeways going up, right? And they're building one of these columns or something like that, you have to form the framework. And that's usually the rebar. So the way I like to think of rebar is like all of the collagen fibers, all of the protein in the bone forms the rebar. Okay? It's the reinforcement. And then the ground substance is like the cement that you would paste onto the rebar. So that's your water, some more organic material, your salts. That's what you form around it. Okay? So that's your matrix right there that you're forming around the rebar. So that's kind of the best analogy that you can come up with to kind of describe what's going on in the bone.
And then the cells are just.
And then the cells live within the ground substance too.
Okay.
Yeah, now if we go back, that's what these slides are about, the cells that we find in bone.
Okay.
Okay. So what are the cell types that we find in bone? Well, number one, you got these guys, osteogenic cells. Yeah, those are usually found in the membranes of the bone. Remember the periosteum that I showed you earlier, the endosteum? Osteogenic cells eventually will become what we call osteoblasts. These guys right here. Osteoblasts build bone. Okay, so blast starts with a B, build starts with a B. So that's how you remember it. Osteoblasts build bone. BBB. Okay. So when osteoblasts build bone, they're making the rebar. They're making the collagen. They're making all the organic material. They're making the water. They make everything except one thing, and that's the salts. Yeah. Okay. Those have to be provided via the blood, and of course those minerals get into your blood via your diet. You have to ingest calcium. You have to ingest phosphate. Now what the osteoblasts can do, as I tell you here, is they can pump those minerals from the blood into the bone and mix it in. But they can't make the calcium or the phosphate from scratch. Okay, that has to come from your diet. But everything else they can make. Okay. So osteoblasts build bone. That's what they do. Now, at some point, osteoblasts retire, as I like to say. And when they retire, they become osteocytes. Okay? So when your bones become calcified and hardened, that's when the osteoblasts are done. So they become osteocytes, they are still alive, and they literally live within the bone. Okay? So they are kind of mature bone cells that hang out in the bone. And they provide structure to the bone themselves. Okay? The other bone cell type, are osteoclasts. Now, these are not derived from osteogenic cells, they actually are derived from monocytes, which are a type of white blood cell floating around in your blood. And what osteoclasts do is they resorb bone. And another name for that is dissolve. They literally break down bone. And you may be thinking, why would you want to break down bone? Well, as we'll talk about later on in the lecture, your bones are constantly being remodeled. Okay? They break down, they build up. They break down, they build up. Okay? Kind of like muscle, right? When you exercise, right? Right? You get little micro tears in your muscle, and the muscle breaks down, but then what do? You build it back up, and that's how you develop bigger muscles and more strength. Your bones are doing that all the time too. Okay? They break down, they build up. They break down, they build up. Okay? And sometimes that happens with exercise and with activity. And then, of course, it can happen with a fracture, where you break down bone and you have to build it back up, and the bone heals. Right? You break an arm, or you break a metatarsal, or whatever bone it is that you broken. So
like certain people train their shins and fight.
yeah, I mean, there are people out there that when they train, they try to train their bones to be stronger, be bigger, to withstand more stress and things like that. So yeah. Osteoclasts break it down, osteoblasts build it back up.
So those microfractures are growing denser bone?
Yeah, there is the controversial procedure of microfractures in a bone, where you're trying to build the bone back up. Sometimes it may work, sometimes it may not.
So it's gambling.
What's that?
You're gambling.
The microfracture procedures are not considered the most reliable.
What about
So-
kicking a wooden fence?
Yeah. So, yeah, they were once way more popular than they are now. Microfracture has also been used to try to build cartilage back up too. So,
Now, what's the backing behind that?
you mean the scientific evidence?
Yeah.
It's kind of lacking.
Okay.
That's why it's controversial. Yeah.
Shake Coach Randy.
Yeah.
Not kicking that football thing again.
So, yeah.
Could you go over how, because every once in a while I run into a patient with a bone growth stimulator.
Oh yeah. Yeah, a bone growth stimulator. Let me see if we can.
He's like, no. That'd be nice. I'd like to reach
Where the
top
hell?
of that.
So here's what happens. So as I said before, bone is always remodeling. Okay. So think about if you're going to remodel your kitchen, right? So what do you have to do first if you're going to remodel your kitchen? You got to demo it, right? Okay. You got to pull out the old cabinets. You got to pull out the flooring, right? The countertops. I mean, if you're going to do a complete demolition, you got to break everything down. Okay. So in bone, as we just said, the osteoclasts are the ones that break down the bone. Okay. Then of course you've got to build it back up. So if you're going to build your new kitchen, you've got to get the new countertops, the new cabinets, the new flooring. And as we said in bone, it's the osteoblasts that do that. Okay. Now, what you hope to achieve throughout your life is balance between these. Okay? All right? You want your osteoclasts and your osteoblasts to have the same level of activity. Okay? So, for instance, if you're going to decide you're going to run a marathon and you start to train to run 26.2 miles, I guarantee you that your femurs are going to get thicker. Okay? To withstand the pounding that you're taking as you train to run a marathon. Okay? So you're going to start to break down some of your bone tissue, but your osteoclasts are gonna build it back up, they're gonna restructure it so that those femurs are in great shape. So you have balance. Okay? Now, unfortunately, as we get older, that balance can be lost. Okay? And when that balance is lost, if your osteoclasts are more active than your osteoblasts, then what's gonna happen? You're gonna lose bone mass. Yeah, you're gonna lose bone mass. Okay? And it always starts off as what we call osteopenia. Osteopenia means you start to lose cells. And if this gets worse and worse, and you start to lose overall bone mass, this is what we call osteoporosis, which is what you're looking at here. Okay, where you lose bone mass. And if you lose bone mass, what are those osteoporotic bones susceptible to do? Break. And you get an osteoporosis fracture. Not good. Now, who's most at risk for this? Elderly. What kind of women?
Menopause.
What kind of? Postmenopausal women. Yeah, postmenopausal women. Okay. So when a woman reaches menopause, what is she no longer making?
Estrogen.
Estrogen. Estrogen helps maintain a balance in females. Okay. All right. So if you're talking about the female body, estrogen helps really maintain a nice balance. Okay. But when you reach menopause, your estrogen levels go down, the balance is lost, your osteoclasts are more active than your osteoblasts. So, when you see a patient that has a bone growth stimulator, those are also trying to restore balance. Okay? You're trying to get their osteoblasts to kind of take it up a notch and match the level of activity of the osteoclasts or even exceed it. So sometimes people with those bone growth stimulators may recently had a fracture, something like that, especially if they're older, then that can really assist them because if they're older, like I said, they're already probably in a little bit of imbalance, and you're trying to teeter that balance back to the other side where they develop more bone. Okay. Men can also suffer from osteoporosis. They're a little less likely because men make testosterone throughout their lifetime. Now, granted, the level of testosterone goes down as we age, but you still have testosterone where this balance is not as disrupted as you would see in a postmenopausal female. So bone growth stimulators can certainly help. As I'll tell you after the break, when we get into a deeper discussion about fractures, there's a lot that goes into how a fracture heals. Certainly your age can play a role, but nutrition plays a big role. That's a huge one. The reduction that they do, which means how well they reduce the bone, which is when they bring the broken bone ends into close proximity, that has a big role in how your fracture heals. So we'll get into some of that later on too. So. For people that have a Y? Oh, OI, okay. So you're talking about osteogenesis imperfecta?
Yeah.
Okay.
Is this what's happening with osteoporosis? Or
No, that's a separate condition. Yeah, osteogenesis imperfecta is more about,
they're more broken?
yes, and it stems all the way back to their childhood where their bones didn't develop properly in the first place. Yeah, osteoporosis, your bones formed normally when you were growing. But as you get older, you lose bone mass. Yeah, when they work you up for osteoporosis, I'm sure some of you have heard of what they call a DEXA scan. Yeah. So let me see if I can find a quick picture. So when they do a DEXA scan on you, you go. It's like a CT scan where you lay down, and this little scanner goes up and down your frame, the scan is estimating your bone mass literally. And if you've known someone that has one of these done, you get what's called a T-score. And the T-score, yeah, here we go, this is a good, let's see.
It's
And-
smaller than like that.
And it didn't make it any bigger. So, trying to find one that has percentages in it. Ah, there we go, that one's better. Beautiful. Yeah, there we go, okay? So when you get your T-score, what you wanna get is a 0. So if there's any exam you wanna get a 0 on, it's the DEXA scan. Because if your T-score comes back as 0, that means your bone mineral density, as we like to call it, is normal. You have not lost any bone mass. Okay? From there, your score enters into the negative zone. So if your T-score comes back -1 or -2, then you have osteopenia. So as I said before, you're starting to lose cells from your bone, so your bone mass is going down. And you can see that if your T-score is -1, you've lost about 10% of your bone mass. If it's -2, you're at 20% of your bone mass being lost. When you get up to -2.5, you've lost 25% of your bone mass. Now you're in the osteoporosis category. Then as you can see, if your T-score is -3, you've lost 30%. If your T-score is -4, you've lost 40%. And obviously, as that T-score gets more and more negative and you lose more and more bone mass, your risk for a fracture goes way, way up. If you were to suffer a fall or something like that, so.
Probably not super important for us, but is there like a gradient to where this bone loss, the bone mass loss happens, or is it gonna be like location, like more like in the hips or?
Yeah, so the DEXA scan gives you an average of all of your bones, and you're right, you could have more bone loss in certain bones over others. So these percentages that you see here is overall, it's not isolated to a single bone or anything like that. They do have machines besides the DEXA scan that you can do at the bedside, where it's like a probe kind of thing, like an ultrasound, where they can put it up to a bone and kind of get an estimation. Those aren't considered as reliable as doing the DEXA scan. But you know, you're going to see lots of patients out there that have osteoporosis, and you know, again, you got to be careful. You know, their bones are not in the best shape, and you don't want to do anything to inadvertently, you know, cause a fracture or anything like that. So, but getting back to your question too, I mean, the most common fractures in patients that have osteoporosis are definitely hips, backbones, so they can have vertebral, and then wrist fractures are common. And the reason why is because if they fall, fall just like you did, they reach out with their outstretched hands, and then they fracture wrists and stuff like that too. So, yeah.
One thing to remember, guys, and I see this all the time in the hospital, out of the hospital, when we are moving these patients and you're grabbing them by the shoulders and pulling them up in bed, especially if they're a little heftier, you will dislocate their shoulder or you will fracture it.
Yeah.
So make sure you're moving the sheets or the material along with the patient and not just pulling the patient themselves up.
Yeah, clavicles can definitely be affected too. Humerus, so absolutely. So, you know, and there's lots of therapies out there for osteoporosis. I mean, that's gotten better and better with time. I mean, it all starts as kind of what they're mentioning here with making sure you have adequate calcium and vitamin D intake in your diet. And if you don't have enough in your diet, to take supplements. That alone is not enough to help treat osteoporosis. There are other meds out there. Some of you may have heard of drugs like Fosamax, which is called Lendronate, Aniva. These are drugs that can slow down the loss of bone mass and help build it back up. And so a lot of people are on those types of meds to help. So, and then of course, if you're a female, there are women that when they reach menopause may decide to take hormones. You know, they can take Premarin or Prempro, and that can help with osteoporosis. It can also help with things like hot flashes and vaginal dryness and some of the mood changes. The problem with taking hormones after menopause is that about 20 years ago, that they started to see data that showed that women that take hormones after menopause put themselves at a little bit of a higher risk for certain cancers and things like that. So it's a decision that she has to make whether or not to take hormones after menopause, because it does carry some risks, so.
Does osteoporosis have anything to do with those old patients at like SNFs that are already like super contracted to where they can't move, or is that just like neglect?
It's like cartilage hardening, right?
Yeah, I mean, certainly when you have osteoporosis, it is gonna affect your flexibility and things like that. My guess would be with a lot of those patients, there's probably other things going on too, that cause them to be that way, but, yeah. You know, and I'm sure many of you have heard of people that have osteoporosis, especially if it's in their backbones, they get shorter, right? That they get more hunched over and, you know, things like that, so. All right, why don't we take another 10-minute break and